Good evening to all of you. Today's KSOS Online Journal Club, we'll be discussing an article published in the Journal of Ophthalmology, the 5-year results of the analyst study. The analyst study is Asymptomatic Narrow Angles Laser Iridotomy Study, which is a study done in Singapore. And today to present this with me is Dr. Reshma Sebastian, Assistant Professor at Jubilee Mission Medical College. The statistics will be discussed by Dr. Sandhya Somasundaran, Associate Professor, Medical College, Calicut. The relevance of this journal to our practice, whether we need to change our guidelines regarding laser peripheral iridotomy in asymptomatic cases, all these will be discussed by 3 of our experts panels here, Dr. Sai Kumar, our KSOS Vice President and Head of Cataract and Glaucoma from Giridhara Institute. Dr. Radha Ramanan, Medical Director, Eye Vision Hospital, Chalakudi, and Dr. Thomas George, who will be handling the discussions, Senior Glaucoma Consultant, Chaitanya Eye Hospital, Trivandrum. Over to you, Dr. Reshma.
Is my screen visible?
Yes, you can start, Reshma.
Okay. Good evening, one and all. Myself, Dr. Reshma Sebastian, Assistant Professor, Jubilee Mission Medical College and Research Institute, Thrissur. Let me take a few seconds to thank Dr. Sudha ma'am for giving me this vast platform to present this journal. The journal is titled The Singapore Asymptomatic Narrow Angles Laser Iridotomy Study. It was a 5-year randomized controlled trial, which was performed by Mani Bhaskaran et al. And was published in the Ophthalmology Journal under the American Academy of Ophthalmology. So before going into the journal proper, let us discuss a few background studies. A study which was most comparable to this study was the ZAP trial, which is also called as the Zhongshan Angle Closure Prevention Trial, which was done in China. What they found out of the study was there was a very low overall progression rate from primary angle closure suspect to primary angle closure or PACG among the untreated eyes over the study period. They found that the laser reduced the risk of progression further from 0.5% to 2.2%. Few Indian studies of significance is the Vellore Eye Survey. Here they found the prevalence of primary glaucoma in an urban South Indian population, and they found that the prevalence of PACG was found to be several times that of POAG, which was far more than suspected or anticipated based on the hospital attendance data. The Chennai glaucoma study, here the prevalence of primary angle closure disease in an urban South Indian population was compared to that of a rural South Indian population, and they found that the prevalence of primary angle closure glaucoma and primary angle closure suspects were similar in the rural and urban population, but primary angle closure was far more common in the urban population. Now coming to few terms which are repeatedly used in the study. Primary angle closure suspect. These are the subjects which are taken into consideration in the study, and it means eyes having an anatomically narrow angle with appositional closure, but without any other abnormality. Now coming to primary angle closure, it means narrow angles along with evidence of a secondary effect that includes the formation of peripheral anterior synechiae, raised IOP, or both. The third one is primary angle closure glaucoma. Here a narrow angle along with glaucomatous optic neuropathy is present. PAC and PACG are the expected or the endpoint outcomes. Now the question arising is whether prophylactic laser PI is actually beneficial in asymptomatic narrow angles. So the aim of this study was to compare prophylactic laser PI versus no treatment in preventing the development of primary angle closure or primary angle closure glaucoma over a study period of 5 years in patients with diagnosed PACS who were recruited from eye clinics in Singapore. So the method was patients were recruited from 5 Singapore eye centers after obtaining a written informed consent. Each trial in all these institutions had to clear the ethical committee. And the eyes were randomized such that one eye was treated with laser peripheral iridotomy and the other eye was left untreated to serve as the control. So there was one baseline visit, 1 week within which the laser PI was done. After the laser PI was done, a follow-up visit, or the safety visit that is called, is done 1 week later. The follow-up visits were at 12, 24, 36, 48, and at 60 months. So the participants had to be more than or equal to 50 years with bilateral PACS, that is more than or equal to 2 quadrants of appositional angle closure with no visibility of posterior pigmented trabecular meshwork on non-indentation gonioscopy. And each patient had to be fit enough to give informed written consent. So the exclusion criteria, if there was an IOP of more than 21 at any of the previous visits, or if there is an IOP spike more than 15 millimeters after pupillary dilatation, if there was any presence of PAS, glaucomatous optic neuropathy, any secondary angle closure, if there was any history of prior incisional or laser surgery, any history of previous penetrating injury, any corneal disorders or opacities that are preventing LPI, if there is any prior angle closure attack, whether the patients were having significant cataract that requires surgery in the immediate future, or persons who are having best corrected visual acuity less than 20 by 40, patients who were using contact lens and patients who were using topical or systemic steroids, and patients who had any other retinal disorders that required frequent pupillary dilatation, and any other diseases which causes visual field loss. And further, any systemic debilitating diseases that reduce the life expectancy to less than 1 year also were excluded. So these were the exclusion criteria. Now, the randomization and masking was done like each patient was randomized by delegated site personnel, and they were given a password secured account through the Singapore Clinical Research Institute randomization website, and each person was given a trial number. The randomization was in selection of the eye. So one eye was randomized to undergo LPI, whereas the other eye was remained untreated. The treatment allocation was not masked because of the nature of intervention. So the procedure, initially a questionnaire was given so as to get the demographic data. So we got the history of any significant ocular or any past significant history was there, whether there was any systemic comorbidities that contributes like hypertension or diabetes, and whether there is any family history of glaucoma or whether they are on any chronic medications. All these were answered in the questionnaire. And at each visit, that is the baseline visit, the safety visit, and the follow-up visit, each of the following were carried out. The best corrected visual acuity at 4 meter with the ETDRS logMAR scale was done. Slit lamp examination was mainly directed at getting the limbal anterior chamber depth by Van Herrick technique, and it was graded based on the Van Herrick technique. The IOP measurement before and after pupillary dilatation, a mean of 3 IOP measurements were taken with the help of Goldman applanation tonometer. Static and dynamic gonioscopy was performed by the Goldman 2-mirror lens, and the angles were graded based on the modified Schaffer's grading. Cataract was graded based on the lens opacity grading system. Optic disc examination and vertical cup disc ratio was measured with the help of a 28 diopter lens and a reticule attached to the slit lamp. The visual field testing was done with the Humphreys field analyzer, and the 24-2 was the program used, the SITA standard. The endothelial cell count was done with specular microscopy. A-scan ultrasound biometry was carried out for axial length, central anterior chamber depth, and lens thickness. Keratometry and pachymetry for central corneal thickness was carried out. So the intervention was superior mid-peripheral laser iridotomy, that is from in between the clock hours, 10 to 2 clock hours were selected. And within 1 week of the baseline visit, this was selected and laser PI was given at this point. This was taken because the iris was thinnest at this point and a crypt was identified. And sequential thermal laser, 514 nanometers, followed by neodymium yttrium aluminum garnet, that is the ND-YAG laser was given. The thermal laser was intended to produce a partial thickness hole, and the full thickness or a complete PI was made with the help of the ND-YAG laser. So before the procedure, pilocarpine 2% was instilled so as to constrict the pupil. Brimonidine 0.15% was instilled so as to prevent the post-laser IOP spike. The settings of the laser was thermal laser 500 to 1000 milliwatts with a spot size of 50 micrometers for a duration of 0.05 to 0.1 seconds. ND-YAG laser, the setting was 2 to 5 millijoules, and the diameter of the PI was 200 micrometers. So once the laser PI was done, IOP was measured 1 hour later. So if there was an increase in IOP of more than 8 millimeter at 1 hour, the person was instilled with brimonidine eye drops, 1 drop, and a tablet of acetazolamide 250 mg stat was given if there was no systemic contraindication, and the patient was asked to wait 1 more hour, and the IOP was rechecked at 1 hour. If there is further increase in IOP, then the person is referred to a glaucomatologist. So after laser PI, all participants received steroid drops, that is betamethasone 0.1% drops every 3 hours for the first day, followed by 4 times daily for 1 week was given. So the primary outcome measure was the development of either primary angle closure or primary angle closure glaucoma. So primary angle closure was defined as the presence of more than 1/2 clock hour of peripheral anterior synechiae formation, an IOP of more than 21 millimeters of mercury verified at 2 separate days, and the development of an acute angle closure event. So acute angle closure event was defined as at least 2 of the following symptoms, which included periocular pain, nausea, vomiting, or an antecedent history of intermittent blurring of vision with halos, in the presence of at least 3 of the following signs, which included conjunctival injection, corneal epithelial edema, mid-dilated unreactive pupil, glaucum flecken, and shallow anterior chamber with an IOP of more than 30 millimeters of mercury. Now, primary angle closure glaucoma was the presence of glaucomatous optic neuropathy with compatible visual field changes. So glaucomatous optic neuropathy in this study was defined as a loss of neuroretinal rim, that is a notch or an erosion, vertical cup disc ratio more than 0.7, nerve fiber deficit attributable to glaucoma, or both. Now, there was a subset of patients which were called as the presumed symptomatic PACS. So these patients had a history of at least 2 symptoms with eye redness, but they did not have any raised IOP. So they thought that this may be because of an intermittent acute angle closure event with an undocumented IOP spike. So such patients, the untreated eye was taken and LPI was performed, and these patients exited the study. So the termination was fellow eyes underwent LPI during follow-up if either of the eye reached the primary endpoint, and the patient exited the study if cataract surgery was required, if there was any retinal diseases, if there is any uveitis that required chronic treatment. Now coming to the results. Out of the 1,084 patients who were screened, only 480 participated in the study and 604 were excluded. 3 eyes did not receive LPI as the patient declined. Out of the remaining participants who received LPI, 58 patients withdrew or lost follow-up. The mean age of the study group was 62.8 years with a standard deviation of 6.9 years. And majority of the patients were women, 75.8%, and the ethnicity was Chinese ethnicity, 92.7%. The systemic risk factors which were seen most commonly was hypertension, that is 47.7%, followed by diabetes, 14.6%. So the 604 persons who were excluded, 333 blindly declined, 48 underwent cataract surgery, 40 there was some amount of prior acute evidence of some amount of acute angle closure attack, and 183 did not meet any other eligibility criteria. So out of the 480 patients who were randomized, 477 eyes received PI, and out of the 477 eyes, 24 eyes reached the primary endpoint. That is, 24 eyes reached either primary angle closure or primary angle closure glaucoma, and 456 were censored at the last visit. Out of the 480 contralateral eyes which received no treatment, 45 eyes reached the primary endpoint. 435 eyes were censored at the last visit. So it was found that a significantly lower number of LPI treated eyes reached one of the primary endpoints. That is, on LPI treated eyes, only 24 reached the endpoint, whereas the control eyes, 45 reached the primary endpoint at the end of 5 years. And this data was statistically significant with a p-value of 0.001. The incidence rate for reaching an endpoint was 11.64 per 1,000 eye years in the LPI treated eyes, compared with 21.84 per 1,000 eye years in the control eyes. This was again statistically significant based on the p-value. The overall unadjusted hazard ratio was 0.52, which indicates there was a protective effect for the LPI compared to that of the untreated eyes over 5 years. The number needed to treat benefit of prophylactic PI for PAC or PACG or both to develop was 22 patients to prevent a single endpoint in one patient over 5 years. The population attributable risk percentage was relatively high for PAS, PAC or PACG or both, and it was 38.3 to 50.8%. The benefit of treatment mainly in this study was because of the reduction in the development of peripheral anterior synechiae, which again was significant. That is, only 1.3% of the eyes that received LPI developed PAS, whereas 4.9% of the untreated eye developed PAS. This was also significant. Now, progression to PACG was uncommon in both the group, whether it was treated or whether there was an LPI. The progression to PACG was uncommon. One treated eye developed an acute uveitis, and it led to a closure of the LPI, and that person developed an acute angle closure attack. Presumed symptomatic PACS, that is, those people who had an intermittent angle closure, which was thought to have that, 4 people had that, and the untreated eyes underwent LPI and they exited the study. So older participants and those with higher baseline IOP after dilatation showed a higher risk of developing primary outcome. Those with diabetes showed twice the risk, but it was not statistically significant. The adjusted hazard ratio based on the demographic data obtained was 0.055 for the development of PAC or PACG. Best corrected visual acuity was comparable between the two arms. The mean angle width obtained on gonioscopy was wider throughout the study during all follow-up visits in the LPI treated eye compared to that of the untreated eye. And this was comparable to the findings on limbal anterior chamber depth or Van Herrick's grading on slit lamp grading also. So the limitations of the study is the field testing that we had that was performed had some reliability issues. Then there was a greater dropout because of the age selected. So majority of the patients had cataract and they had to do cataract surgery. So there was greater dropout. Then it was impossible to mask the intervention because that might have led, both the observer and the subject knows which eye is lasered. So this might have led to a bias of vision or IOP. So the conclusion of the study is untreated PACS shows twice risk of developing endpoints over 5 years. But the factor is the overall progression rate is very low. So they have concluded that observation without LPI was a reasonable option for PACS. It's just similar to that of the conclusion obtained from ZAP trial. Thank you. Now moving on to statistical analysis to Dr. Sandhya. Thank you.
Thank you, Reshma. Can you just stop sharing?
Yes.
So that is a good description of the study. Now over to Dr. Sandhya for describing the statistics.
Hope my screen is visible, madam.
Yes, it's clean.
Is my screen visible?
Yes.
Okay. First of all, let me thank Sudha madam for giving me an opportunity. So Dr. Reshma has well presented the journal, which has made my job easier. So let us see regarding the statistical analysis. So the study, as you all know, it is a Singapore asymptomatic narrow angle laser iridotomy study. 5-year randomized results of a randomized control trial. Now, first of all, before going to the journal proper, if it is a randomized control trial, we have to see whether this journal is according to the consort checklist, which has to be followed while presenting a randomized control trial. So for that, we have various guidelines given in the consort checklist. For that, the title and abstract should be identified as a randomized trial, and there should be a structured summary of trial design, methods, results, and conclusion. So first we will see regarding the title and abstract. So the title is Singapore Asymptomatic Narrow Angles Laser Iridotomy Study, 5-year results of a randomized control trial. So the title appears to be precise. Then it includes a study population, that is asymptomatic narrow angles, patients with asymptomatic narrow angles. Then intervention, yes, it is mentioned, that is laser iridotomy. Then duration, it's also mentioned, that is 5 years. Then design, it's also mentioned, that is randomized controlled trial. But what is not mentioned is the outcome. What is the outcome? It is not mentioned. Now, regarding introduction, as Dr. Reshma has presented, it gives a proper scientific background and explanation of the rationale, and there are specific objectives or hypotheses. Then regarding methodology, the consort checklists say that they should describe the trial design, they should describe the inclusion criteria, exclusion criteria, settings, location, everything has been described well in the study. Now, what is the study design? It is a randomized controlled trial. So it is open label. What is open label? Open label means that there is no blinding. So they also have said why blinding could not be done. Because of the nature of the procedure, blinding could not be done. Then it is a paired eye. Paired eye means one eye is used as a treatment arm and the other eye is used as the control arm. So as Reshma said, eligibility or inclusion criteria, exclusion criteria, everything is well mentioned. Now regarding randomization, so as per the consort checklist, they should describe everything regarding the randomization. What is the type of randomization, how this randomization is done, etc. So randomization basically helps to avoid selection bias and it helps us to get comparable groups to compare. So here they have done randomization using Singapore Clinical Research Institute randomization website. So what is the intervention? It is laser iridotomy. And what is the outcome? It is either primary angle closure or primary angle closure glaucoma. So they have included primary angle closure as either that is more than 1/2 clock hour of PS formation or IOP more than 21 or development of acute angle closure. So this might have led to their higher number of cases maybe. Then again another outcome is primary angle closure glaucoma, which is defined as presence of glaucomatous optic neuropathy, changes with visual field loss. Now sample size calculation has been done based on the formula for sample size calculation for clinical superiority trial. So randomized control trial can be of basically 3 types: superiority trial, equivalence trial or non-inferiority trial. For example, in this situation they have said that laser PI is superior to the observation. So it is a superiority trial. If it is equivalence trial, it means that the laser PI and observation is almost equivalent. Non-inferiority trial means our procedure is not inferior to the existing treatment. Now results. As per the consort checklist, they should give a consort flow chart that Dr. Reshma has described well. That is how many patients have been enrolled to the study, how many have been really enrolled into the study, how many have left the study, like that. Now, regarding to the, first we'll deal with the results. First, in any study, first we have to say about the baseline characteristics. That is what is the age, gender, ethnicity, like that. Then this is the regarding the baseline characteristics of both eyes. Here you can see that this is the laser iridotomy group. This is the control group. Almost all the parameters are so similar. So this may be one reason, maybe that they have used, it's a paired eye, that is the other eye of the patient is used at the control. That is the reason why these results are so similar in the both that is treatment and the control groups. Yes. Then regarding the statistical analysis. In this article, following statistical tests have been done. First one is Cox Regression Model. Second is McNemar test. Third one is number needed to treat. So before going to the statistical analysis proper, we'll just see what is time to event analysis or survival analysis. A survival analysis, more appropriately called a time to event analysis, considers not only if disease occurs but also the length of time from the initial observation to the subject to its occurrence. For example, in this patient, it measures or it analyzes the time from the laser iridotomy to the occurrence of angle closure. Whereas okay, so there is another term called as termination of follow-up or censored data. What is that? That is, for example, here these are the patients we are enrolling to the study. These are the patients who are eligible for the study. This is the start of the study and this is the end of the study. So many patients have to be terminated or censored in between, either due to one outcome has occurred in between the study, that is before the end of study, or they might have had some untimely death or some reasons like that, or due to any reason if they have to be excluded from the study, These data are called as censored data or termination of follow-up data. So the peculiarity of time to event analysis is that these censored participants are also included in the analysis. But this is in contrast to the analysis of binary outcome data. That means if we only study whether angle closure glaucoma occurs or not without analyzing the time between the laser iridotomy to the occurrence of event. That is called as binary outcome. That is, we are just analyzing whether an outcome occurs or not. So if the analysis of such type, then we cannot include these censored participants. So that is the advantage of this time to event analysis. So what are the statistical tests used in time to event analysis? The most common tests are Kaplan-Mega test, log-rank test, and also Cox Regression Model. So what is this Kaplan-Mega test? Kaplan-Mega test analyze the survival rate. For example, in this situation, how many persons will not develop angle closure glaucoma at a given point of time? That is analyzed by Kaplan-Mega test. So this will analyze how many patients will not develop angle closure glaucoma in the laser PI group and also in the control group. So log rank test measures whether this difference is statistically significant. The third one is Cox Regression Model, which is the statistical test used in this journal. So what is the advantage of Cox Regression Model over the Kaplan-Mega test? So in Cox Regression Model, we can analyze the hazard rate or hazard function. So what is the hazard function? Hazard function represents the risk of occurrence for the outcome at a given time. For example, in this situation, what is the risk for occurrence of an acute angle closure event? So hazard ratio means the hazard rate in the intervention group divided by hazard rate in the control group. So hazard rate can be measured only in Cox regression analysis. It cannot be measured in Kaplan-Mega analysis. So if hazard ratio is more than 1, it indicates that there is higher rate of events among the intervention group, and if it is less than 1, it indicates a lower rate of events among the intervention group. So we want a hazard ratio less than 1 to know that if the intervention group is significant or if it is better. Now this is Kaplan-Mega curve. Kaplan-Mega curve is a pictorial representation of the survival analysis. Here you can see a blue line which denotes a laser peripheral iridotomy group and a dotted red line which denotes the control group. So here you can see, for example, at 3 years, this laser peripheral iridotomy group definitely has lesser number of eyes developing angle closure glaucoma when compared to the control group where more number of patients develop angle closure glaucoma. So this is how we analyze the Kaplan-Mega curve. Now regarding the analysis, you can see that development of primary angle closure glaucoma or both, the raw data is 24 persons have developed out of 477 have developed acute angle closure or both in the laser PI group, whereas only 45 have developed the angle closure event in the control group. Then you can also see the hazard ratio as we have mentioned earlier. If the hazard ratio is less than 1, it means the intervention group is far superior. That is, the hazard rate is lesser in the intervention group. Here it is 0.52 and the confidence interval also is good. Yes, it is 0.35 to 0.7. If the confidence interval does not cross 1, then it is significant. The p-value is also significant. Here you can also see the incidence rate per 1000 years. What is that? It is that if you follow 1000 eyes for a period of 1 year, the patient that is in the laser PI group, only 11 persons will develop the event, whereas in the control group, 21 persons will develop the event. Then you can see the peripheral anterior synechia. Regarding peripheral anterior synechia also, the hazard ratio is very less and p-value is also significant. So in this study it is said laser PI really helps in preventing the formation of peripheral anterior synechia. But you can see that IOP elevation to more than 21, that is not statistically significant. Here the p-value is 0.639 and also the confidence interval has 1 in between. So that is also not statistically significant. The other way around also you can see the angle closure. That is also the p-value is not significant, and angle closure glaucoma also the p-value is not significant. The only significant thing what they have got is basically peripheral anterior synechia and also the development of PAC, PACG of both as total. Then next is McNemar test. So what is this McNemar test? McNamara test is used to determine if there are differences on a dichotomous dependent variable between the two related groups. So what are the dichotomous dependent variable here? That is no endpoint or endpoint in both peripheral iridotomy and in the control group. So McNamara test determines that whether the number of patients who develop laser or the proportion of patients who develop acute angle closure in the laser peripheral iridotomy group and the proportion of patients who develop angle closure glaucoma in the control group, whether this difference is statistically significant. That is measured by the McNamara test. So here they have mentioned that that is statistically significant with p-value of 0.001. Now next is number needed to treat. So what number needed to treat is the number of patients who need to be treated to prevent one additional adverse outcome. For any trial which has reported a binary outcome, the number needed to treat can be obtained as a reciprocal of absolute difference in proportion of patients with the outcome of interest. For example, in this study, they have given number needed to treat as 26 for primary angle closure. That means we have to treat 26 patients with laser iridotomy to prevent an occurrence of primary angle closure. Again, that is NNT is 103 in PACG. That means to prevent occurrence of PACG, we have to treat 103 patients. So that is a significant. Ideal NNT is 1. Now next is population attributable risk percentage. Population attributable risk is a proportion of incidence of a disease in the population that is due to exposure. It is the incidence of disease in the population that would be eliminated if exposure were eliminated. The population attributable risk percentage of PACS, that is, so in this situation, the risk is primary angle closure suspect. So, it is said that the risk of this primary angle closure suspect patients to develop primary angle closure of glaucoma is 38.3 to 50.8% in this study. Or in other words, they can also say that to prevent occurrence of 38.3 or 15.8% of cases, we should do laser iridotomy to remove the risk. So that is the statistical analysis. Now we will see how this can be clinically interpreted. So over to the next section. What is the clinical relevance will be discussed next. Thank you.
Thank you, Sandhya. Very nicely statistics have been discussed. Now, whether we need 26 patients to prevent primary angle closure. So is this and 103 patients to be treated to prevent glaucoma? So is this significant and is this likely in our scenario? Over to Dr. Thomas George for guiding the discussion, for starting it.
1 second, before TG starts speaking, I must really congratulate both the presenter and the discussant for really analyzing this in depth, and of course thank Sudha for I have watched a few journals in between, but this is the first time because I'm a discussant. I'm sitting through this. It's really wonderful, and I think as president-elect, not vice president of the KSOS, I think it makes me really proud that we have come so long. It is a very, very high quality stuff that we are viewing today. I'm sure a lot of people will watch this in YouTube over a period of time. It was really, really wonderful. I was just engrossed in the way all our young ophthalmologists are presenting this and discussing this. Sorry, TG, for intervening. Please go ahead with the discussion.
Sai, only thing is you said what I wanted to start with. Okay, well done, Dr. Sudha. Reshma, you have actually touched upon all the references that I actually looked up for this discussion, and the statistics were beautifully done. You could say that you couldn't do better than that. Now, to put it all into layman terms, I would ask the senior most among us, Dr. Radharamanan, to tell us what is the take-home message of this particular RCT. It's the strongest model of any intervention study, RCT, and this particular one, what is the take-home message?
First of all, like Sai and you said, it was a wonderful presentation by both of them. Actually, it was so nice. It covered everything. So when we discuss in a clinical presentation like this or in a journal, we usually discuss on both parts. One part is about postgraduate things, how they can follow up these studies, and research people. So that part is beautifully done. So that is a very typical. And now the second part, that is what you are asking, how we apply into our clinical. That is basically for the practicing ophthalmology. So this is the second part we are coming into it. So I think this study, the first part is showing that this is so valid, and we have to take the points out of this study. So what are the points? That's your question. And this is, I think, it is similar to what we were believing in all our clinical experience, because we were thinking that all PACS need not to treat, and all PACS need not to reach in glaucoma or even into angle closure. So, but it is showing that 50% reduction, that we have to take it in the study, it will be 50%, but NND is only 26 in angle closure. So a similar study, SAP study, is showing that it requires more than 126 NND. And why this both are based on Chinese population. This is also predominantly a Chinese population, that also in a Chinese population, but both studies is showing a prominent difference. And the article also discussed maybe due to the selection of the people. So that means that is what we are clinically more interested, because those who are coming in the population, and SAP study was based on the community selection. And this is based on the hospital patient selection. So that itself is showing a greater difference in both studies. So that is very important, but definitely it reduces the risk. So we have to think which cases we have to think. I think we'll discuss that in the further things.
So I'll address the next one to you. Would ethnicity make a difference? Because ZAP study was in southern China, and Singapore study was predominantly Chinese extraction population, not necessarily all from southern China. And we are dealing with Indians, where the only data we really have about incidence is Valorai survey on PI and no PI. And they said the ones with PI progress 1/3 risk compared to the ones who refused PI. So would ethnicity make a difference?
In angle closure, it looks like, because all the studies we are again putting in the Asian population. But when you are comparing it to the other side of the globe, actually it is not coming into. So India also, there are different studies showing that South India and North India is, to some extent, it is different. So ethnicity is there in angle closure, definitely.
Sai, what's your take on this?
Yeah, I think ethnicity definitely makes a difference. And if you look at the spectrum of angle closure all over the world, you have the Chinese eyes on one end, you have the Indian eyes probably somewhere in the center, and you have the Caucasian eyes at the other end. So definitely ethnicity would make a difference. And if we have a similar design study in India, probably we will get a better answer as to whether the NNT matches with this, whether the same hazard ratio is applicable to our population and things like that. So I think ethnicity does matter. And you have also mentioned the Vellore eye study. I think you were in Vellore at that time when the study was done. The numbers in the Vellore eye study is much higher. You know, the conversion into PACS and PACG were quite, PAC and PACG were quite high. But probably the criteria used in different studies may be slightly different. That is why the numbers are, so different. But I look at this from a slightly different perspective. Now, we are doing a lot of number crunching now from a purely statistical and scientific way that we are looking at. And it should be that way. I'm not saying against it. But if you look at the sheer numbers of angle closure glaucomas in the country. And if you look at if you convert it into the actual number of eyes or patients in a huge country like India, even if you prevent blindness in a set number of patients, I think your clinical sense should prevail more than any of these numbers while deciding which patient goes in for an LPI or not. You can't just say that no, you don't fit into the criteria of the analyst study, so I won't do a PI for you. I think on a raw clinical basis, a day-to-day examination, your experience, and if you what I have followed over the last few years are the guidelines by the AIOS. I'm sure we all have read that, and that says, if I may just quote from that, it says PSCS should undergo peripheral laser iridotomy if the fellow eye has either PSC or PSCG, need for repeated dilatation, systemic medications that may provoke pupillary block. So a huge list of things are there, which sort of covers many a patient in that. So I think instead of looking at the real NNT and things like that, whenever you feel there is a small risk or one feature, a local loss of pupillary rough, a small iris atrophy here or there, any sort of risk, I think I would err towards the PI group rather than waiting and watching.
So I would add patchy pigmentation of the trap meshwork also. That is more commonly seen than the PAS itself. I totally agree with Sai. Glaucoma is not a disease that's amenable to population screening like cataract. There's no easy screening technique, whether it's open or closed angle. All we can do is case detection. The person who comes to us, we look for glaucoma. And that is actually a small number. There's no point in talking about opportunity cost. This time could have been spent elsewhere. This money can be spent elsewhere. Because the guy in front of you, you use your clinical decision and go ahead. Sai, one more question I'd like to ask. They have used argon equivalent diode laser followed up with YAG as a PI option. We rarely do that. We rarely need to. Would this also be something to do with ethnicity?
Probably yes, because and I think they have, although they mentioned it as sequential, I think they're doing it in the same sitting. Correct me if I am wrong.
Yes. Same sitting. Laser 1 followed by laser 2 at the same sitting.
Same sitting. Yeah. So whenever we have had to do this, it would be sort of very thick iris where high power YAG doesn't penetrate. Then we do a small crypt with an argon, wait for a week, and then enter through with a YAG. This is something that I have done in some cases, but most of the cases probably you wouldn't need to do that in Indian eyes. I'm not really sure whether the irises are thicker in the Chinese eyes, whether that is one of the factors why they have more incidence of angle closure, or it is the overall dimension of the eye that is smaller compared to the Indian eyes. I'm not very sure of that, but I think that would definitely be a factor.
I've actually interacted with Arun Narayan Sami and Bhaskar on this study in another forum. And the reason is the Chinese iris are much thicker than Indian iris. They are both people who have worked in Shankara Nitralaya and the SNI, Singapore National Institute. I mean,
TG, can I just ask one question here?
Yeah, please do.
What is the method of gonioscopy that is employed in this study, and how would the switching of gonioscopes really impact our day-to-day management of these?
Okay. Having said that, they have used a 2 mirror, which is good enough to pick up a PSCS. And they have done a dynamic, basically an indentation
manipulative gonioscopy.
Manipulative gonioscopy, as we call it, to pick up the PAS, which will pick up 90% of it. Only if it doesn't actually push the iris back visibly, in my clinical practice, that's what I do. Do I need to pick up the 4 mirror? But 4 mirror is definitely much, much better than a 2 mirror to pick up a synechia. So if you have to buy one gonioscope, buy a 4 mirror. Sussman or Zeiss or Posner, one means it's an indentation gonioscope. But I have the luxury in my institution.
Would some Plato irises be missed with a 2 mirror?
And not really. Plateau is actually better. 2 mirror gives you a better view finally. The 4 mirror, you see that one point that you're trying to indent or that sort of thing. 2 mirror gives you a much better view. And plateau won't be missed. What will be missed is a low synechia and some iris which is thick and lens which is pushing forward a little too much. Those we will not be able to open up with a 2 mirror manipulated gonioscopy. You still need a 4 mirror.
I think I am also addicted to, I have to use the word addicted to 2 mirror because start using it and once after 2 mirror, I takes in a few cases only uses the 4 mirror. Maybe the younger people, I think they have to start with the 4 mirror. I think after using it a long period, sometimes we psychologically a little more addicted to that.
No, but screening for angle closure is, I think the 4 mirror Sussman is the fast way to go and just, without coupling fluid, just put it in and see whether this needs a PI or not. As simple as that. One of your colleagues or optometrist or, someone brings a patient to you and say, I have a doubt. Can you just see whether this patient requires a PI? That's a clinical decision making. For that, at least in my practice, I just put in a Sussman. In a minute or 2 minutes, you make a decision. If you want to really enjoy the view of the angle and look at every crevice and all, I'm sure the Goldman is definitely better.
Yeah, I agree. Sussman is much faster, less messy, and it's only a patient who is a little uncooperative and wants to blink too much. It's a big problem. Then you still need a 2 mirror. Also, if you need to look for secondary glaucomas, where you need to spend some time studying the angle, you still need a 2 mirror. So it's actually, I would say the 2 lenses are complementary to each other. You should be comfortable with both the techniques. And when you're starting to learn gonioscopy, of course, 2 mirror is easier because it gives you more time in the angle. But faster, eventually 4 mirror is the way to go. No doubt about that. Dr. Radharaman, what do you think of Van Herrick's as a test?
Van Herrick's, you have to consider either you are sitting in the glaucoma OPD or in a general OPD. General OPD, if you don't have time, Van Herrick is useful. But as many studies have shown, like even your value study has shown that it is not up to things to follow. I think, but in a regular practice, in countries like India, it is not that easy to do gonioscopy in every case, even though we advise something. So we should, one thing is we should never miss a Van Herrick's. Okay, if it is totally, you don't have any doubt, okay, you forget about it. Suppose you have any doubt about this thing, you proceed with the gonioscopy. And some of the people used to advise that you do 100% of cases gonioscopy. Practically, in a general ophthalmology clinic, it is not that easy.
Absolutely. Actually, we published a study when I was in Vellore on Van Herrick's being poor predictor for occludable angles is what the title of the study was when we published it. The thing is, when a Van Herrick says it's closed, its sensitivity is only around 60%. So you got a test which is sensitive to 60%, but a specificity of 90%. So net effect is, Van Herrick's is good to say the angle is open, or rather when the Van Herrick's is negative, you're almost sure the angle is open. But when the Van Herrick's is positive, you have no idea whether it's closed or open. So what Radharaman sir said is, in absolute lay terms, the way to go, if a Van Herrick says guy is safe, he's safe. If he says he's suspicious or not safe, you still have to do a gonioscopy to say he's safe or not safe.
This is exactly what is mentioned in the AOS guidelines also. So it says that if you have a grade 4, you're safe. The angle is open. You can go ahead and dilate and not do anything. If you are in 3, 2, or 1, don't take the Von Herrick as a guideline. Go in and put in a gonioscope. I think that's a very, very valid point that you have raised.
Now, Sai, the other thing is, most of us have, classical teaching is PI is a definitive treatment for relative pupillary block, which is a primary cause of angle closure. So it sort of gives you a message that, okay, you do a PI, this guy is safe forever. What do you think of the follow-up situation after this study has come out?
Absolutely not. PI is definitely a good treatment option for PACS, PSCG, but that is not the end of the story. So all patients who have undergone PI need regular checkup. I usually call them 2 weeks later after the PI once, and then 3 months later. And if everything is absolutely fine, healthy discs and all, I call them every year. And having said that, there are quite a few patients who have all these criteria but have raised IOP. So they have a patent PI, the discs look very good, but still the IOPs are 24, 26. I don't know whether I have the backing of any scientific study on this, but I do start them on medications. Clinically, you can argue that this is the disc is normal, the field is normal, you can wait, watch and all. But in an angle closure situation, unlike in an open angle situation, I am not very comfortable with ocular hypertension. I don't know the view of the others on this, but I do start them on treatment. Quite often it's a prostaglandin, because prostaglandins have been shown to be very, very effective in the angle closure situation with a patent PI. And this is what I do. And definitely they have to be followed up. Many of them, some of the Plato irises, as I mentioned before, although the numbers are not very high, you may have to use long-term low-dose pilocarpine. There are a few patients of mine who are on once daily pilocarpine for many years, and their pressures are well controlled. They have huge, large open PIs, but still, even if you stop the pilocarpine, the pressure goes up. And many of them, in spite of all this, progress into a angle closure glaucoma as well. So PI is definitely not a one-point treatment in angle closure spectrum. You need the patient to be under a very, very strict follow-up, just like any other glaucoma. This is what I follow.
At that, I would say that there are multiple mechanisms that are postulated for angle closure. Pilocarpine also can be a double-edged sword. If you have anteriorly rotated ciliary body, anteriorly placed lens, it will worsen. So there is no escaping gonioscopy before PI, after PI. When you initiate treatment with pilocarpine, sometimes even after dilatation, it may give you some info. Each time you do a gonioscopy, it may give you a different info than what you saw at baseline. That is absolutely the way to go. And another thing that Sai said, I would like to underline, whenever you have any sort of IOP above 25, you have to be careful. And this is something that came out in the last KSOS interaction in that international symposium with Dr. Spade. And he's very specifically spelled out. It is not glaucoma alone that we are bothered about with intraocular pressure. If you got pressures over 30, you are expecting a CRBO also. So anything about 25, I would be uncomfortable leaving untreated. Dr. Radharaman, what's your take on that?
Actually, I totally agree with both of you. Actually, when you are doing a YAG-PA clinically, you should not explain to the patient that by doing a YAG-PA, according to this study also, we should not explain to the patient that you are going to prevent any glaucoma after that, because this is sometimes happens and some patients will be moving from. And maybe pupillary block will be relieved to a good extent. Actually, this study also 3 pupillary acute angle closure was recorded, 2 in the untreated cases and 1 in the treated. Even the treated cases, actually the PA closed and then it affected like a acute angle closure. That means if PA was helping all cases in this study also, that it was preventing an angle closure attack. But when you are doing a PI, the angle is not going to open it like anything. So it will be slowly will be coming, and some cases it won't have any impact at all. So in this study showing that all are deeper, but some few cases in our experience, it's not opening up. So we have to regularly follow up the patient. That is a must. So there is a problem with the patients also. Once you do it, even if you explain to the patient, most of these patients won't come for the follow-up. Some of the patients after 3-4 years comes with a ankle closure glaucoma that we could have prevented it. And so we have to explain to them in a little more tougher way, so that whatever we are in the study, we will be telling yearly review and all. But practically, it is not that possible unless you give emphasis to the patient.
Can I ask something? In our population, creeping angle closure, they say, is very significant. So does PI help in that?
I don't think PI will help in this creeping angle closure. Whatever the terminology, I think it is a very questionable term.
No, I'll take that. Classically, we have been taught that pupillary block may have a role in creeping angle closure. That is, our population, we have a lot of people going straight to a chronic closure stage without going through the acute angle closure stage. But we have no real proof on that, because we have not done an RCT. We don't have a population study that has proved that or any of that sort of thing. It's just a postulate. We still wondering why closure occurs in some patients. It's not all pupillary block. At this stage, let me throw in the next one, the lens vault. Lens vault is now being looked at in a big way for closure, especially studies from Korea and Singapore. And China have been underlining it. And of course, we had the Eagle study before that. Sai, what do you think of that?
Yeah, I think, I personally have a feeling that when you look at many of these eyes, even with a patent PI, you do a gonioscopy over the hill, you feel that the angles are open. But the mid periphery, you look at it and you find that it's really bulging. Those are the eyes with the very thick lenses. So that is what we look at in the lens vault. So the terminology was popularized after we got into an ASOCT and things like that. Before that, it was just a clinical observation. Now again, if I may quote the guidelines that I usually follow, the vault, the total anteroposterior lens size it is mentioned that if it is above 5. And if the AC depth is less than 2, so these are the situations where the lens vault definitely has a role to play other than a pupillary block mechanism. And these are precisely the eyes which may benefit from lens removal. So if you have a very significant lens vault and the patient has an early cataract, a bit of nuclear sclerosis, maybe even 6/9 vision, the pupil dilates well, you got a patent PI with no risk of a mid dilated angle attack or increase in pressure. These are the eyes to me which definitely benefit from cataract surgery.
I think I agree with Sai. I think we were discussing about Van Herx, about peripheral depth. Similarly, I think we have to discuss more about the central, the anterior chamber depth. So whenever you get a anterior chamber depth very shallow, because this is very easy to find out in relative, easy to find out in clinical experience. But with the introduction of OCT, anterior segment OCT, we start measuring more, and it is not practical to measure every patient unless in a glaucoma or in a specialized setup. But if you want to, like Sai explained, if you want to select it for a clear lens or a initial starting cataract cases, if it is a clear lens, we will be very much hesitated to remove it. If there is an element of cataract, you won't have any hesitation. But the decision making, this ACD, anterior chamber depth on the central area, will be a very useful depth. And also it will be helpful during surgery also, because you can end up in trouble.
If I may just add, TG, just one point regarding, it's not in the purview of this discussion or this topic, but cataract surgery in these eyes has to be, no need to mention that, extremely careful. We routinely do a specular in these patients to know the condition of the cornea. And the technique of surgery itself, we modify to keep the anterior chamber much deeper than normal, raise the pressure a bit more, do a bit of anterior, even clear cleanup all around before we start our trenching. So there are various techniques that we use for cataract surgery in an angle closure situation, especially if the cataract is more harder. So I think that is again a point that we all need to consider and really know this technique to prevent any corneal damage during cataract surgery.
I was just going to say that again, last 2 years have been golden years as far as I'm concerned for Zoom meetings internationally, and I had the opportunity to discuss with Tin Nong, again Singapore group, about lens vault, and he said that the consensus is coming out as 1 millimeter lens vault would be a risk we should look at eventually. 1 millimeter lens vault means your phaco probe will barely be able to go into that anterior chamber. It is not for any surgeon. It is for probably somebody at size level, not even for my level, to do a cataract.
A millimeter vault. 1 millimeter vault is deadly.
That is what
even the other. Yeah. So 0.5 is something that you can manage, but a millimeter of vault is it's going.
You'll be relying heavily on Helon to give you space all the time.
Heavy viscoelastics. Your rexus has to be extremely careful. The rexus can, and in these situations, if you lose the rexus, then you are in deeper trouble.
Rexus is very difficult because you're sitting on a very convex lens, and you are scared you will hit the decimals. So that is it.
Really tricky.
Having said that, the only thing I would do in an angle closure differently is, if I think it's even a PACS and there is some cataract which I may say do it or not do it, I would say do it. I would go for an earlier cataract surgery. I am not comfortable with the idea of a clear lens extraction. What is your take on it, sir? Radharan, sir.
Definitely, but if the condition is worsening and you discuss with the patient, suppose if the lens is go on increasing, you're observing this thing and getting angle more and more closer. There are only two cases I think I have gone for a clear lens extraction till now, and that too after discussing with the patient, I was so hesitated to do it. The patient condition was getting worse, and patient was going for patient already developed glaucoma, and this patient was so much worried. All this condition actually began, but we have to take it very carefully. Not I have seen plenty of clear lens extraction based on these things, but maybe in some part of the Kerala you will be seeing a lot of this thing, but very hesitated, because the hesitation is very simple to disturb a naturally perfect human body structure. So, but if it is so much indicated, we have to go for. But if there is a cataract starting, as Thomas pointed out, once it is started, you know that definitely you are going to operate it. Then should not wait for any more time, because anyway you are going to operate it. Don't wait for a more complicated cataract surgery also. Not only for glaucoma, but also for the more complicated cataract surgery, because if it comes to a hard one, when the AC is very shallow, you are going to produce more of endothelial damage. So if it starts, no doubt, if the cataract starts, lens vault no hesitation, go for surgery.
Just one point here, TG. This concept of lens vault, I think there are no eyes where you have a pure lens vault phenomenon. These are all eyes. These are all eyes with compromised angles. They have shallow chambers. They have an element of pupillary block, and on top of that, you have this lens vault. Because if you look at all these eyes, you feel that once you do a cataract surgery, these eyes looks like absolutely normal. In fact, if you look at the slit lamp in post-op follow-up, you see that they are not as deep as the normal cataract eyes. They have a bit of shallowness. The intraocular lens is sitting slightly anteriorly. It's all your block is cleared. Your lens vault is done with, everything is there. There is no glaucoma. There is no pressure. But the position of the IOL, if you see, is slightly anterior. So I personally believe that there is no eyes with a pure lens vault phenomenon. It is just an add-on with a compromised angle.
I have to agree on that, because angle closure, primary angle closure that we talk about is not a single animal. There's pupillary block, there's plateau iris, there is what you call anteriorly placed lens iris diaphragm, lens vault. You have your ciliary body that is tending to rotate, similar to almost a Nanoff situation without an obvious ciliocoroidal effusion. All these, and in a given patient, you would have a combination. I have also seen quite a few of the plateau iris becoming deeper with the cataract surgery and an IOL, and some who still stayed shallow and went on to zipper up. I have no idea why the plateau behaves differently in two different patients when I take off the lens and create a lot of space in the back. Sometimes it just doesn't fall back.
This is true, but there is nothing in the medicine like we know everything about that thing. And nothing in the medicine we can solve everything by a single procedure. So in all these situations, what is best on that situation. So if that is there, you have to tackle it. But again, it points out the same thing like a PA, it is not the end of the procedure. You have to follow the patient. If you have a glaucoma patient, you and patient will be lifelong, nothing else.
So can I ask you a question, sir?
Please do, please do.
Sir, do you get any case of severe anterior uveitis following PA?
Yes.
Yes. So recently we had one patient. So
Sanjay, PI is not a totally innocuous procedure. I do see people who need prolonged steroid use once in a year or so. I have even had one patient on whom I had to do a hyphema evacuation because the patient went home without a hyphema but came back in 3 days with a 2/3 chamber hyphema. That is not on equaspirin or clopilate or any of those stuff, but that can happen in as a surprise. So PI is not totally innocuous. Also about 6 or 7 years, more than that, when I was working in the regional institute, that's 10 years ago, I've had a patient who had the first half an hour later, the pressure was 50 something and she was tending to vomit. That's nausea feeling, everything was there. And it was not a closure. It was post-PI IOP spike and I had to give mannitol. So all these severe stuff comes once in a way, but they're rare. Luckily, that's
Luckily,
rare.
they are rare. Even a typical malignant glaucoma is described, although I haven't seen one. TG, probably you would have seen. But luckily, they are, if you look at the sheer numbers of PIs that we do and the sheer number of blindness or glaucomas that we prevent using a PI, they are luckily rare.
Said, see, N and T we are always discussing, but N and H is there. Number needed to have. So here it is there. This study they have pointed out is almost 0, but it is not always 0.
I think NNH would be more for eagle study results, clear lens extraction. You can really do damage.
George, can you just sum up? I just want to know what is the consensus for patients if you are seeing patients and they need frequent dilatation, even the first dilatation to see the retina. Would you suggest that yes, if the AC is very shallow, we will do a PI, or would you suggest that?
Absolutely, absolutely.
TG, we have not
patient-
highlighted this 10% incidence. I think that is one of the most important things that come out of this study.
That's true. The conversion rate from PACS to PAC has been shown as 10% in this study. And that is exactly what we found out in the Valorai study. And that was 11% there. So that probably is a number we can go by, because we got a population study from South India, which has shown a 5-year conversion rate of 11%. Chennai glaucoma study also came somewhere nearby, I think it's 9 point something. And this one has shown 10%. So if you see a PACS, the conversion in 5 years should be around 10%. That I think can be taken as a proof.
What would that convert into sheer numbers in a country like India?
Huge.
Huge. We only see the tip of the iceberg in our OP, and that's all we can go by.
That is where I'm concerned with this, pure statistical approach to things. I'm not against, as I said, against any of these studies. They are all needed. We are all scientific people. We all need to go by RCTs and things like that. But 10% of conversion in sheer numbers is huge. Even the 100%, I mean the 100 NNT to PACG, again, if you look at the numbers, it's quite a bit. But again, we are not sure whether a PI would prevent all this. That is the other part of things.
Saida, other side of the story is PAC still is not a blinding disease. In both the Vellore study and the Chennai study, 5 years, nobody reached PACG. Nobody.
Okay.
And here they were lucky to get a couple of 3 acute angle closures, and which is what has sent them into the PACG group. If they hadn't had those 3 acute closures, which are more common in the Chinese population, they wouldn't have had any PACG. So
that I think comes back to that. I think brings us back to Sudha's question about the zipper-like closures and the ones we really first detect with typical glaucomatous changes, just like in a POAG, but with an angle, but with an angle which is like an angle closure.
Absolutely. That is why I always underline, more than treatment, it's a follow-up and compliance to follow-up that matters for the patient. And to get that, there's only one thing in our armamentarium that I have found out over years, that is build a rapport with the patient. Make the patient believe, or rather make the patient understand that you care for the patient. Otherwise, he's not even going to put your drops. The drops burn. Why should I do it? That would be the question. But if he thinks you care for him, he may put it because he wants to please you. That may be there.
As an offshoot of this, since there are a lot of medical college professors here who teach a lot of MS students, how many of your MS students are confident in doing a gonioscopy, a good gonioscopy to rule out an angle closure?
I think not very many. We do recommend doing a gonioscopy. As you said, the 4-mirror gonioscopy, we are not teaching them. They are doing the 2 and single mirror and 2-mirror gonioscopy. Ultimately, they'll have to only when they go into glaucoma practice, but they learn better. But yes, we are teaching them that it is important to look at all patients after the age of 40 or 50 to go do a gonioscopic screening if there is a suspicion that your peripheral irises or peripheral anterior chamber is shallow.
What about Reshma, Sandhya?
Yeah, routinely they do gonioscopy, sir. But by the time they reach final year, yeah, most of them are, I think, confident. But the thing is, that wedge, corneal wedge and all, they are not so familiar. So if they see the pigmented trap, they can well say that it is open angle. But other way around, not so sure actually.
I generally,
They do it regularly. Final years are confident. Others are slowly learning.
that's very heartening actually.
Yeah.
That's very heartening. I do insist, or rather, I do recommend that the PGs buy a gonio lens, and not everybody obeys me. And the ones who buy actually learn. The rest who have to borrow don't really learn. That's what I have found out. We need to come back to Dr. Sudha's question. A person needing frequent dilatations, would you do a PI or would you observe? Right.
I would do. I am very, pro PI, if you may call it. So any doubt, I usually do a PI. We have quite a few of these diabetic retinopathy patients in our, OPs. Many of them actually they send to rule out whether look at the angle, please look for new vessels and things like that. But then we find that the angles are none of that is there, but the angles are really shallow, and we know that these patients are going to be dilated quite frequently. So I do recommend PI for whenever I feel that frequent dilatation is required.
Absolutely. I'll share a case that happened a couple of months back. Somebody had a PI, both eyes, actually done by me in 2013, and was being followed up and then was referred in with a CRVO with an NVG in one eye. And on seeing it, one eye PI was patent, other eye PI was blocked, and now has an NVG with a CRVO. So the PI getting blocked with pigment, if it was on follow-up, would have been picked up, and probably the CRVO itself would not have happened. That's the flip side of what Sai said. Our patients can't be trusted for follow-up always. So I would err on the side of PI also.
So I think that has been a very fruitful discussion. Let us wind up I hope all of you enjoyed the program, going through it. Thank you so much for coming and contributing.
Thank you. Thank you. Good night.
Thank you.